Good evening, everybody. Good evening. Today we have a good round table about terminology called super cholesteatoma, somewhat new term. But I think about cholesteatoma, we have the famous type or traditional cholesteatoma, which arise lateral to the aortic capsule. This super cholesteatoma may be medial to the aortic capsule or the extensive cholesteatoma. Classical cholesteatoma may be congenital or acquired, and the acquired may be secondary or primary. The congenital cholesteatoma appears like a white mass behind the normal eardrum, normal pars tensa and pars tensa and pars flesta, no prior history of perforation or otorrhea. Congenital cholesteatoma can occur at any site in the temporal bone, and it can mimic or simulate any disease of the temporal bone. The acquired cholesteatoma is classified in its management into three types, either epitympanic or attic cholesteatoma. This attic cholesteatoma may be anterior attic or posterior attic or superior attic. And the cholesteatoma inside the middle ear called the mesotympanic cholesteatoma, and the cholesteatoma filling the mastoid and the middle ear is called the holotympanic cholesteatoma. Super cholesteatoma refers to extraordinary forms of cholesteatoma regarding site or extent. It may be massive cholesteatoma. The CT scan shows erosion of the posterior tegment and the lateral semicircular canal. The other types medial to the aortic capsule. It may be the SIB angle. This MRI T2 showing hypertense shadow in the SIB angle compared to the cerebellum. The same after T1, hypointense shadow in the SIB angle. The same after T1 with gadolinium. Super cholesteatoma may also be present in the petrous apex. The petrous apex may be primary in the petrous apex or secondary to big cholesteatoma in the lateral to the aortic capsule. This MRI shows T2 hypertense shadow in the SIB angle. This one. The same after T1. The same after T1 with gadolinium, diffusion MRI. Now we have our speakers, our dear friends, Professor Abdelhamid Ben Ghanem from Morocco, Professor Aliane Carocci from France, Professor Nicola Quaranta from Italy, and Professor Magid Bayer from Egypt, and Professor Isam Saleh from UK. We can begin with Professor Abdelhamid. We speak about myoric cholesteatoma.
شكرا جزيلا. Thank you, Mr. Moderator. Thanks, Mr. Chairman. And I answer to, can you switch the mode of presentation, then I can control the video, because I cannot control the videos with this mode. Thank you. I named it my worst cholesteatoma, but because I was in the definition of super cholesteatoma or extended cholesteatoma. I did already an instructional course about this extended cholesteatoma, and tried to find a definition making a difference between invasive ear cholesteatoma or Petrus cholesteatoma, because sometimes you have middle ear cholesteatoma going and growing around the aortic capsule, and sometimes also Petrus cholesteatoma are coming outside and going to the fascial nerve, the muscular canal, and fascial palsy. So what does it mean, in fact? We had a very nice introduction. Is it aggressive or worse cholesteatoma because of the location or because of the size or the extension? Is it about the importance of bone destruction or the complication? We have seen the possibility of fascial palsy, labyrinthization, kyphosis, or surgical difficulties, and all these complications make the surgery very difficult. And here is our series during 10 years, and we have 530 cases of middle ear, classic, I'll say, mild extension, but we have this rate of middle ear cholesteatoma with huge extension and real petrous bone cholesteatoma, and 39 cholesteatoma with fascial nerve problem, carotid, meninge, intracranial recurrence, and we will see some example. Are we talking about these difficulties? We have been educated with our mentors 30 years ago. Don't touch to the fascial nerve when you have a cholesteatoma. Don't touch to the matrix when you have cholesteatoma on the foot plate. It's absolutely wrong. We can do all this in the same stage, even if sometimes it's a nightmare to remove the cholesteatoma from the foot plate, but we can do that at the end of the surgery when we finish cleaning and resection of the cholesteatoma everywhere. And then we can remove the cholesteatoma from the foot plate without harming and without any fistula, and it's absolutely possible. But we don't talk about this. We're talking about this case, for example, petrous bone cholesteatoma, and that was the question of dear Ali Mahrouz before. When you have this, it doesn't work. When you discover after 4 surgery, I got this cases when I finished removing, I went to the fascial nerve, and after stimulation, there is absolutely no possibility to let this fascial nerve like this. So what I decided, the decision which the patient was informed before, and we have to do something and to remove this part of the fascial nerve, then we need a little bit more length. So here I'm cutting the petrous nerve, and then I have more length of the fascial nerve. And the worst decision is this moment that we have to cut it, to chop it, as said Ali, because it doesn't function. It's totally distracted. So we need to graft it. And why I prefer giving more length, it's because the result of termino-terminal anastomosis is much, much better than with the cable graft. We have to know, because there is a question before, that can we suture? Yes, in the third portion, mastoid portion, we have a perineurium enough solid, then we can do a suture. But in the second portion, and especially in the fourth portion, it's very difficult to suture because there is no perineurium. We are going to pass now some situation when you start doing, this is not a surprise. We must not have any more surprise during the surgery. We must have a real and perfect assessment, CT scan, and sometimes MRI, to know exactly what are we going to find during the surgery. And when you found this lateral sinus so close to the canal wall, what you want to do? You can do canal down, but you can also do this, like translabyrinthine approach or sclerotization of the lateral sinus, and then transform your otology to otoneurology, and then you can have enough space to remove the bone between and in front of the lateral sinus. And sometimes, unfortunately, we have both. You have meninge and sinus precedent. And that moment, in this situation, sometimes with the patients and reducing the diameter of the burrs, we can access to all the parts, but you can also help with the endoscope if you have hidden areas. And sometimes when it's worst, when you can do nothing more than this, when you have a very precedent sinus, very precedent meninge, we cannot access to the antrum, we cannot access to control everything on the attic. Then I did in-out mastoidectomy and clearly canal down initially, and we can at that moment access to all the part of the middle ear. And it was also a very good indication for canal down because of the size. And less the volume we have in the mastoid and better is the result of canal down. Sometimes in the petrous bone, we can have this situation with very extended cholesteatoma and invading the dura. And that moment, we need to be very careful and dissect the cholesteatoma from the supralabyrinthic extension. But at the end, we will have a large defect on the tegmen tympani and tegmen entry. And yesterday was a discussion, how can we repair this defect? By infratemporal approach or by mastoid? We have a nice series of autolicoria with the large defect on tegmen, and we did the reparation through the mastoid with the hard top, with the cartilage, and sometimes I use part of the cortical with the condition to have the hard top and the soft top that's been very étanche and very stable reparation. I don't know if you see this kind of complication that was very often 25 years ago. When I was in hospital, we received always mastoiditis and MPM, cerebral abscess. And the discussion was, do we have to call the neurosurgeon? Do we have to postpone to do the abscess and after the cholesteatoma, or we can do both in the same time and finish to clean everything. And here we are in retrosigmoid and extradural part of the temporal. And we finish with drainage, passive drainage, and cure. We are going to switch to another kind of cholesteatoma. I'm sure that we will have a very nice conference with the colleague coming. There are the problem with the petrous extensive cholesteatoma. I'm going to do it very quickly and just to stress some aspect important that sometimes we have multifocus of cholesteatoma. That means when you finish cleaning, it's appear that the temporal and the mastoid are clean, but just find 1 millimeter of matrix, and we are going to find a huge extension, especially supralabyrinthic extension. Like this, when we finish with, we thought that we have no more cholesteatoma, but drilling more, we will find just through the very small cells a very important extension of the cholesteatoma.
Doctor, your time is
Okay,
up.
just 1 minute, and then I conclude. I will skip the So to avoid surprise preoperative, we have a very important stage. It's assessment preoperatively, CT scan and MRI. We have, because we need a roadmap to not have any surprise. We need also to adapt on perioperative our technique, because even sometimes we can have some extension, inattended extension. The learning curve is as everywhere for the surgery, and never trust on cholesteatoma. It's a traitor, especially in extensive ones, and very long follow, especially now with the MRI non-EPI. Thank you.
Thank you, Professor Bilghalib. And now we're calling Professor Alian Karochi will speak about obliteration.
Yeah, dear colleague and Mr. President, I am a little surprised to be in this round table because I am going to speak about normal cholesteatoma, not so much technique. So I am here, I am going to give you this lecture. Perhaps it's not exactly in a good situation. So you know that now we have now a very good progress in cholesteatoma, in the diagnosis, and also in surgery by the endoscopy, and also by the radiologist by MRI. So you can speak about only one cholesteatoma. There is several cholesteatoma. And if you want to do your strategy, your surgical strategy, you must think that there is not only one cholesteatoma, there is some different cholesteatoma. And there is a classification from Mr. Fraisse. And I think it's very good in your practice to have this mind in your brain. So the classification depends, of course, of the route of evasion are determined by the route of ventilation. And the most important, you have isthma anteriorly, you have posterior anteriorly, you have the membrane of the chapel, and of course, the epitympanum anterior. And also it depends on the compartment of the middle ear. So you have compartment that I showed you before, and I go fast. You have your epitympanum, posterior, anteriorly, and the most important is the cock. You know that if you have some problem when you do surgery, if you want to be sure that there is no problem, you must to see the cock anteriorly part. And you have the mesotympanum, and also you part about epitympanum. But you know what is the evolution, excuse me, of the cholesteatoma. And like this, you have anteriorly and posteriorly epitympanic, and with extension lateral, median, mesotympanic, and holotympanic. So if you take about, you speak about epitympanum posterior, your posterior epitympanotomy cholesteatoma passing through the superior inguinal stapes and go to the adductus and antrum. If you speak about epitympanum anteriorly is with extension to genicular ganglion. And of course, mesotympanic, you have the only big problem when you do this kind of surgery is your sinus tympani and the facial recess. More often, the recurrence of cholesteatoma is in this area. It was very important to see very well, and also what brings now the endoscopic. And you have all that you call holotympanic cholesteatoma. The holotympanic testament can part from epitympanum posterior, but also from the retrotympanum and go inside. You have different cholesteatoma, so you must adapt your strategy, your surgical technique. You have this kind of technique for that. You have canal wide up with a transcanal episiotomy, canal wide up with anterior episiotomy, canal wide up with posterior tympanotomy. I don't perfect now with posterior tympanotomy because the endoscopy can give me more results than a posterior tympanotomy for to be sure about my sinus tympani. And you have a combined approach. Of course, your canal wall down technique, and now I try to explain what is obliteration technique. So I want to show you my experience. I begin to be old, and at the beginning of my study, you do more canal wall down and canal wall up, and you see that slowly and slowly you reduce the number of canal wall down to go up more canal wall up with endoscopy, and slowly they operate the obliteration technique. At the beginning, you have problem for the material obliteration technique, but now with the bone technique, it's better. And you can see now I do more canal wall down canal well done technique, that canal well up, canal down, excuse me, I do no more canal well done, I do more canal well done obliteration and canal well up with obliteration. And I do, because my diagnostic is more often and is more near now, and you do a transmetal athecotomy. So why the ablative technique? The ablative technique consists of a meticulous reconstruction and obliteration of the mastoid. Theoretically, the obliteration technique should not permit recurrent cholesteatoma to appear, like retraction pocket, or reduce the number of residual cholesteatoma due to the weed exposure. But also, you have also more importance in the open cavity, because it should avoid the disadvantage of open cavity, recurrent infection, water intolerance, caloric-induced vertigo, and difficulty to wear hearing aids. Why do you de-obliterate it? But you do exactly what natures do. You have a normal mastoid, you have sclerotic mastoid, and you have a mastoid with bone. And who attack with rehabilitation open cavity? You have autologous material. You see that you know that with the time, muscle fluid, bone, cartilage, fat, but always you have some risk of resorption and iterative voteria and wide cavity. And now they appear a biocompatibility material until silicone, and now we go to the bioactive glass with a complete change, because there is no infection. There is sometimes, excuse me, infection and expression. I'll speak some words on titanium because I come from Marseille, but I will show also I will not a good result. But for me, I changed completely my strategy of surgical when I go to Professor Stekers and Bernardeschi, who show me the interest to use bioactive glass. The interest of bioactive glass because with the other material that is very easy to use and it has antibacterial property. And now it's very easy to use, and you have a very good osteointegration with bone alive granules. In one day, you have only hydroxyapatite like this on surface, and after you have hydroxyapatite, we remove all the granules, and you have osteointegration in 3 months. So why you do this technique? You do this technique because you improve the aeration of middle air. And you know that if you look some literature about the middle air gas, you can see that with this technique of surgical, you reduce a mucosal surface for gas engines. And in this case, the epithelium, residual epithelium don't go so fast, and you can reduce the effect of eventual residual cholesteatoma. And now, like this, you can have more success. And why also? Because when you do a technique, of course, when you must do a second look, you don't know at the beginning if it's fibrosis or it's recidive for your cholesteatoma. In this case, you do a second look. But now with a bone, with a technique with a bone alive, you have an image like this, and you can see very well the difference, and you can avoid a second look. And it's not a new technique. This technique was described by Mark, and it's a Belgian surgery, and they do like this. In case when there is recurrent cholesteatoma, and when the mucosa of endotympanic is inflamed, it plays a polyp. And of course, if the middle ear is better vented, and you do a paratympanic space obliteration. And the paratympanic is the attic and the mastoid. And it closed with cartilage. When you do this technique, you must to close off. You must to put like a frontier between the middle ear and the past of the mastoid. You must to close completely. And when I was performed before posterior tympanotomy, that I told you before, now I don't perform posterior tympanotomy in this case because I have the endoscope. So if you want to do this technique, you are careful. You must to reconstruct very well. You must to take every space you must recover to try to put some piece of cartilage. You must to block completely the space. You must to have, if you have the possibility when you do surgery, you must to conserve the posterior part of external canal. So you can propose this technique. Well, it's finished. Only if you have complete cholesteatoma removal, and the endoscopy gives you the good quality. If you have a doubt, it's better to do obliteration with conjunctive tissue. I go fast if it's possible.
Dear doctor.
Yes, but I finish. So advance, it's one technique that I do. Must with the epitympanotomy obliteration, you must do after tympanic graft and osteoplasty, and you have obliteration of the epitympanum space over the second portion of fascial, and you reconstruct by fascia and cartilage. It's only a small video. If it works, it's better. It's possible to work. Yeah or not? It's only for to show you. It's very simple to prepare. You are with your nurse with the serum, salad serum. You put on syringe and you obturate this like this. And after, when you finish, you put the fascia. You are obliged to recover. And we do this technique to avoid granula in the middle here. I put some gel form like this to be sure that there is no problem. But in follow-up, there is not a problem. So for when you do this technique with open cavity, the advantage that you have no go down is not necessary to drill more the canal technique. So I used cartilage for to rebuild tragal and cartilage, and you put fascial. And the most important, and I finish by that, is necessary to be a follow-up with MRI, because with MRI you can see very well T1, the cholesteatoma, and bone alive. If you deficit-weighted MRI, you have hyperstignal, and you are with bone alive, you have only hypo. And like this, your follow-up it will be better. And I have not in my series more than say 50 years. I have no problem with the, as you know, the silent cholesteatoma. So I finish. Well, it's not necessary to go more fast. I go, mastery that I do is a sure effective technique. I do more now in first insertion, and you have a good tolerance. But of course, you need to have a very good follow-up by MRI. And I do 1, 3, and 5 years. Okay.
Thank you, Dr. Cartucci. Dr. Nicola Quaranta for the Petrus bone cholesteatoma.
Well, thank you for the invitation. I've seen in the program that we were 3 or 4 to talk about Petrus bone cholesteatoma, so I thought would be more interesting to present one or maybe a couple of cases if we have time, in order to have some discussion at the end. There are particular cases that we have treated in the last year. In the last few years. This is a 63 years old man that was treated in 14 years ago, or 13 years before the second operation for a left PBC, Petrus bone cholesteatoma, by a translab approach and blind sac closure of the external auditory canal. He had a long-standing facial palsy that was treated with static procedure. He did not present for follow-up, and when he presented in 2022, he presented with a worsening of the right hearing loss and also with a complete facial palsy on the right. He was practically bilaterally deaf with no any response with the hearing aid. So this is the CT scan, and he was already operated on the left. He presented with a massive Petrus apex cholesteatoma on the right side. And this is the T2 3D MRI that show the cholesteatoma that involve the petrous apex, and I will just show you here. So we have a patient that has been already treated, and okay, doesn't stop. Okay, anyway, this was the petrous bone was affected. So we have the patient that was already treated on the left side completely by a translab approach, and a profound hearing loss on the right with a petrous apex cholesteatoma that involved the posterior labyrinth with also a complete facial palsy. So we had two problems, facial palsy and also hearing loss. So what we decided was to remove the cholesteatoma by a subtotal petrosectomy translabyrinthine approach and put a cochlear implant in without reconstructing the facial nerve. The facial nerve was completely, maybe I can skip this video, we go to the next one. Okay, this is the right side, and this is the cholesteatoma into the petrous apex that was also involving the internal auditory canal. So we had to drill, go translab, and then reach the internal auditory canal. There was some CSF coming out from the canal, and so we could complete the removal of the cholesteatoma from the petrous apex. And as you will see also by removing, resizing the dura of the internal auditory canal that was involved, trying to save the cochlea that was here. Facial nerve was completely infiltrated and was then removed. This is the eustachian tube. So this is the cochlea. Now we can skip a little bit. Okay, this is the dura of the internal auditory canal that was infiltrated by the cholesteatoma. Need to remove the dura and the 4 nerves into the canal, trying to save the cochlear nerve. So remove all the cholesteatoma and the infiltrated dura, and then we have this situation with the petrous apex that was cleaned by cholesteatoma, CPA, with the 7th and 8th cranial nerve. So we obliterated the more medial portion, and then, oh, sorry, maybe I skipped the obliteration. And then we put the cochlear implant. So close the tube with wax muscle and fat, and then close the everything. And this was the intra-op transimpedance matrix that was normal. No NRT intraoperative, but this was the first map. And then over the time, it started to present some, this was the tonal audiometry, but it started also to present some speech audiometry. And then we went for a reconstruction, a rehabilitation of the facial nerve by a 5th, 7th anastomosis. Is using, this is the data logging that shows that he used the implant for 12 hours a day. The second case is, so this was, I think, a quite interesting case. We can have some discussion about the way of treating this kind of patients. This is a lady, 41-year-old, that present with bilateral hearing loss, bilateral ear discharge and vertigo, and she has a bilateral perforation with cholesteatoma on the right side. This is the hearing with let's say mostly sensory neural hearing loss on the left side, and mixed mainly conductive hearing loss on the right side. But this is the CT scan. So we have a middle ear cholesteatoma that involves the infralabyrinthine area, infralabyrinthine cells, and reach the jugular bulb. This is more clear on MRI, T1 with contrast. This is the jugular bulb. This is the cholesteatoma. And as you can see here in coronal view, there is a contact, at least, between the jugular bulb and the cholesteatoma. The problem here is that on the left side, we have a hypoplastic sigmoid sinus and hypoplastic bulb. This is T2, and this is the reconstruction. As you can see, this is a dominant sinus. So we have on the right side a dominant sinus that is infiltrated or probably infiltrated by cholesteatoma, with hypoplastic sigmoid and transverse sinus on the left side. Infralabyrinthine cholesteatoma, so we went for a subtotal petrosectomy, blunt sac closure of the external auditory canal, removal of the, of course, of the tympanic membrane remnants, removal of cholesteatoma, and then I just show you a couple of video. This is the left side. This is the third portion of the facial nerve that was completely that was involved 360 degree by the cholesteatoma, with an infralabyrinthine apical extension that I will show you. And this is the jugular bulb. Okay. This is the infiltration of the seventh cranial nerve. So we try to remove as much as cholesteatoma as possible and try to clean all the facial nerve without mobilizing it. And this is the last part with the cholesteatoma that infiltrates the jugular bulb. Of course, since this was a dominant bulb, dominant sigmoid sinus, we couldn't be too much aggressive. And of course, we couldn't close it as we can, for example, do with a petroccipital transsigmoid approach. So at the end, we just left this matrix on the jugular bulb, obliterated with the tube with wax and muscle. Of course, obliterated the cavity with the fat, and this is the post-operative bone conduction. Of course, we left some matrix on the bulb, and we're going to follow up the patient because she will have probably a recurrence. But this is another, I think, interesting case that we can discuss maybe at the end after the other colleagues will present some other cases on petrous bone cholesteatoma. Thank you for your attention.
Thank you, Professor Karanta. Next speaker will be Professor Magid Bayer of Egypt, speak about petrous bone cholesteatoma.
Okay. As we all know that petrous bone cholesteatoma is a very rare pathology. It accounts to up to 3% of all cholesteatoma cases that we see. Most of them are congenital in nature, but in about 30% they are secondary, and this is a very important issue to tackle because, as you see, this case has been following with a colleague of mine, and he had cholesteatoma, regular cholesteatoma with radical cavity done for him, and with follow-up he found residual cholesteatoma. In 8 months period, this patient came back with hearing loss, sudden deterioration of his hearing, and when he followed him, he found destruction of the petrous bone, here infralabyrinthine destruction by cholesteatoma. So this in 8 months, an iatrogenic formation of petrous bone cholesteatoma. This is a case of a supralabyrinthine cholesteatoma that we operated upon. You see here the tegment has been eroded by the cholesteatoma here and here. And this is left here. And as you see, we have managed to operate and remove the petrous bone cholesteatoma here through a wide canal down mastectomy with obliteration of the middle ear totally. Infralabyrinthine cholesteatoma, this is the case I was just discussing, the heterogenic case that was referred to our department. The cholesteatoma filled the infralabyrinthine portion of the middle ear. And this is a short clips. This is the facial nerve here. This is the tegment there. This is the mastoid tip here. This is the middle ear cavity. And we are doing preserving the facial nerve because the facial nerve function was intact, but the patient had a complete hearing loss. And you can see a glimpse of the cholesteatoma here matrix medial to the facial nerve. This is the lateral canal being drilled out. Working with the facial nerve needs continuous irrigation to prevent injury due to thermal effect. And this is the cholesteatoma sac dissected medial to the facial nerve. But this is just the start of the journey. We need to clean and make sure that we have cleaned every bit of cholesteatoma matrix from the middle ear before attempting obliteration, because we don't want to leave any matrix behind. You see here, the matrix is being dissected from the oval window here. And then this is the quest for completing the our. Okay. This is a case of an apical cholesteatoma here. And this is like a nasty type of cholesteatoma because it involves a carotid artery. The carotid artery is in the venue of our surgery. We have the superior petrosal sinus, and this is a kind of a very intricate area to operate on. So this is, here we are with a right ear, and the cholesteatoma is in this area. This is the cochlea, which has been drilled out to gain access to the petrous apex. And we have to work between the carotid artery, which is in here, in an attempt to gain access to the petrous apex this way. So we have, since the patient has complete hearing loss, this is the second tube orifice with the instrument inside it. So this is the carotid artery in here, and we work and we drill the cochlea to gain access to the petrous apex here. There, the facial nerve was intact, so it was not drilled out. Now we have opened the petrous apex. We are now ready to get the cholesteatoma out. Here we go. So here we have the second tube. Here we have the carotid artery. These remain of the cochlea, and the facial nerve is kept intact, untouched. Once we have finished that and extracted the cholesteatoma, we attempt obliteration by obliterating the second tube orifice. As you're going to see now, we are going to fill it with fascia, a muscle plug, then with the bone pate and bone wax, whatever you have, you just chop it off inside the second tube with cul-de-sac closure of the external radial canal. The last case is a more aggressive one, an infravertine apical cholesteatoma. You see how much the destruction shows on the CT scan, coronal CT scan here and there, filling and expanding and causing osteolysis of the petrous apex. Now this is another video clip of the right ear. This is the facial nerve. It was intact. And we have drilled out the labyrinthine block totally. And this is the dura of the posterior cranial, of the middle cranial fossa, the posterior cranial fossa being removed, or being denuded from bone. And this is the cholesteatoma. See how huge it is, filling medial to the facial nerve and anterior to the facial nerve. So we have to drill out the facial nerve. This is a kind of a transotic approach, keeping the facial nerve intact in place because the patient had it retained facial nerve function. You have to be patient because we need to remove the cholesteatoma as a one bulk, so not to be left with pieces of shreds of cholesteatoma matrix afterward. So the cholesteatoma is out, and again, this is not the end of the story. We need to follow every bit of matrix since we are going to fill the cavity with fat and do cul-de-sac obliteration. And this is the cavity after kind of completion. You see yeah, why it is very important to follow every bit of and shred of matrix, because you will find, take your time and follow every, remove every bit of matrix, because this is very important and mandatory if you're going to obliterate.
Dear doctor, your
Maybe
time
just
is up.
give you just half a minute or something. Yeah, I will finish up. So I think we don't need the video a lot. Okay, nothing else. Okay, so the main thing to take home as a message is that radical removal takes a priority over hearing preservation. So our quest or our aim in this type of surgery is to eradicate the cholesteatoma completely, because it's a life-threatening and priority is over hearing preservation. Thank you very much.
Thank you, Dr. Bear. Dr. Aysam Salah, petrous bone cholesteatoma.
Okay, thank you very much for staying late till this session. We have talked a lot about petrous bone cholesteatoma. My talk is also about petrous bone cholesteatoma, the surgical challenges. And as everyone noticed, surgical cholesteatoma, if we try to define petrous bone cholesteatoma, I would say simply it is a cholesteatoma that is deeply located to involve the deep part or the petrous part of the temporal bone. It's nearly 4 to 9%. In my series, it's even less. It can be congenital or acquired. I usually follow, that's not my photo, by the way. I am much older than this. I follow standard classification, which is supralabyrinthine, infralabyrinthine, apical, massive, and apical. So the supralabyrinthine is the commonest form, and it usually is located above the labyrinth, centered over the nuclear ganglion of the facial nerve. And that's why in these cases we find a lot of cases do have really facial paralysis. The infralabyrinthine is centered in the infracochlear and infralabyrinthine cell tract. And the infralabyrinthine apical is, again, infralabyrinthine, but it's more extensive to involve the petrous apex. So it will be just not only the infralabyrinthine, but also involves the petrous apex. The massive is centered on the otic capsule itself, so it will really entail a significant and variable degrees of destruction of the aortic capsule. And again, we usually find facial nerve paralysis or paralysis in these cases. The apical is the least common. It is congenital, it's not iatrogenic, and it's centered on the petrous apex. So why is petrous bone cholesteatoma different? Why do we have a session even on this? Because usually it has a different presentation. In the majority of cases, we have inner ear erosion with concomitant sensory neural gloss. We might have more facial nerve paralysis other than the normal cholesteatomas which we see, and it is deeply located. So we need a definitive skull-based approach to tackle these lesions. And because they are deep, they have, and because they are very extensive, the recurrences are much more than the ordinary cholesteatoma. So what are the problems? The problems is that we can involve vital structures, we said already, inner ear, facial nerve, but also the internal carotid, sigmoid sinus, jugular bulb, and the dura. So this is an example of the inner ear involvement. The lateral canal is completely eroded by the cholesteatoma, and by the way, during surgery, the bone was already gone, but the membranous turbans completely fibrosed. Internal auditory canal involvement, and the internal auditory canal is not a big deal. You have to tackle it, we do a translab, but the problem is the dura is very thin, and removing the cholesteatoma, as we have seen in the beautiful videos that demonstrated before, removing the cholesteatoma from around the dura of the internal auditory canal usually entails opening and getting CSF, and you have to be careful not to injure the nerves inside. Then facial nerve involvement is also a problem, because in a lot of cases, the facial nerve is encircled by the cholesteatoma, and really it needs special tackling. This case, for example, that's the facial nerve here, as you can see, and the cholesteatoma, the facial nerve is completely exposed. The cholesteatoma is underneath the facial nerve, and really removing the cholesteatoma from underneath the facial nerve, you have to be careful. You see the facial nerve is suffering a little bit here. That's the facial nerve. And there is a matrix of cholesteatoma which managed to remove at the end. But because of these manipulations, that patient was having a normal facial nerve and ended up with a grade 3, but he improved to grade 2 after 1 month. Dural involvement. The middle fossa dura is very sturdy, and so removing the cholesteatoma from the middle fossa dura is possible. However, sometimes it sticks too much, and you might have residual cholesteatoma over there, and in such cases, you do bipolar coagulation of these areas you suspect. The posterior fossa dura is much, much more difficult because it's very thin, and you have the possibility of having a lot of CSF leak, especially if a very large area of the posterior fossa dura is exposed. Again, the sigmoid sinus and jugular bulb, and it will be a nightmare if this is the only sigmoid sinus or jugular bulb, as we have seen in the previous case. We can have good hearing or acceptable hearing like this case. However, the cholesteatoma is extending medial to the labyrinth, and it's very difficult. This was a recurrent cholesteatoma. That one was operated by a subtemporal middle fossa approach by a neurosurgeon, imagine, and he had, of course, a recurrence. And you have to remove the labyrinth in this case because the cholesteatoma is just medial to the labyrinth. And you see, once we did a labyrinthectomy, you will be astonished how much cholesteatoma was left. It's just, we had an extensive cholesteatoma in the mastoid, in the middle ear, eroding even eroding partially the cochlea. But once we drilled the labyrinth, you see how much cholesteatoma is found there, just medial to the labyrinth, and in the exposing the internal auditory canal. So the surgical approaches depends on the site of the cholesteatoma, preoperative hearing, facial nerve. Sometimes you might even use endoscopy, and it's very useful really. And these are just the approaches. I'll not go through this. This is an example that has been a 44-year-old male, and he did have fibrous dysplasia of the temporal bone, as we can see here, and he was operated elsewhere 14 years before presentation, and they closed his ear as cul-de-sac, but they closed on epithelium. So he developed this very huge cholesteatoma, which is an infralabyrinthine apical. See, this is the very huge cholesteatoma, in addition to the fibrous dysplasia on the ipsilateral side. He was deaf, and his facial nerve was grade 1. So this is the cholesteatoma. As we see, it's very extensive. It even involved completely the petrous apex and the carotid. That's the diffusion-weighted images. And it involved also the occipital condyle, the petrous apex, and even there was a small part in the neck. So that was the surgery. Once we opened, we found the cholesteatoma just bulging, and the facial nerve luckily was not injured, and it was saved. But as I said, it was very extensive. All the posterior fossa dura, all the middle fossa dura were exposed. These just glimpses from the surgery. And you can see that the facial nerve has been here hanging. The posterior fossa was exposed through all the, so we were protecting it with this aluminum because we really had a significant exposure of the posterior fossa. The cholesteatoma, as we are dissecting it from underneath the facial nerve here and here around the jugular bulb, and towards the carotid, which we had to at the end to really liberate the carotid and reroute it a little bit in order to get the remaining cholesteatoma that was there. You see, this is the carotid artery. It has been slightly mobilized, and this is the cholesteatoma in the petrous apex. And here the jugular, the occipital condyle had some cholesteatoma. We couldn't drill actually the occipital condyle because that will lead to instability of the neck. So this is the occipital condyle, and at that stage, I wanted an endoscope. Unfortunately, all the scopes were not available that day, and that was really terrible because I believe there was a part of the cholesteatoma was left there. This is the post-op CT, and he fortunately got a grade 1, and the cholesteatoma was actually 13 centimeter. It was really huge, and his facial nerve is grade 1. Now, this patient came to me after 2.5 years, maybe from surgery. He has, again, a residual cholesteatoma, which I suspected was the area of the occipital condyle, and I scheduled him actually next month for doing revision. So these are just some of our cases. The majority were supralabyrinthine, but infralabyrinthine, apical, and massive are also present. Usually, we do translab, transotic, subtotal petrosectomy according to the case, according to the hearing, according to the patient, and according to the extension, of course, of the cholesteatoma. In very, very few cases, I didn't do cul-de-sac closure because it was a very limited petrous bone cholesteatoma, which I could obliterate completely the area with a cartilage and leave it open. But the majority, we do cul-de-sac closure. But cul-de-sac closure definitely needs, you do it because if you have exposure of vital structures like the carotid and the dura, or if you have a fear of CSF, if you open the internal canal or the posterior fossa dura and your approach is very deep, then you will definitely have a recurrence if you leave it open. Facial nerve management, we did cable grafting in 2 cases. They were a little bit late. That one was, he presented with grade 6 after 7 months. For 7 months, we did cable grafting and he recovered to grade 4. But this one, luckily, he was grade 3. Just in 1 week, we did just decompression and he recovered to grade 1. We had only one case that had a grade 1 and then got transient grade 3, but he again recovered. Some cases came very late with facial nerve, maybe 3 or 4 years. Of course, we send them for rehabilitation or reanimation with the plastic surgery. Now, the last thing, follow-up is very important. Give me 1 minute only. The last, it's very important when you do MRI diffusion-weighted. Can I have 1 minute? When you do diffusion-weighted images and they give you this white thing and they tell you, okay, you have a recurrence. Be careful, always associate the ADC map because cholesteatomas are hyper-intense in the diffusion-weighted images, but are gray, hypo-intense in the ADC map. So when they are both hyper-intense, that is not a recurrence, that is not a cholesteatoma, that is something else. And in case you doubt, because really the radiology report comes, you have a recurrent cholesteatoma. So in case of doubt, you just follow up and see if this lesion grows or not. And usually it doesn't. If it is a cartilage, sometimes fibrous tissue can present like this. So the take-home message at the end, petrous bone cholesteatoma are challenging, high risk of sensory hearing loss, facial nerve, and you need to have a variety of skull-based approaches at the end. And most cases, as we said, need obliteration. And at the end, diffusion-weighted images is needed for regular follow-up. Thank you very much for your attention.